Thank you so much for the invitation to be here today and to speak with you all. It's a privilege for me to be able to come to these events, and I will do my best to try and distill complicated information into usable nuggets of knowledge that you can take back home with you. So again, my name is David Coffey. I'm an assistant professor in the Division of Myeloma at the University of Miami Sylvester Comprehensive Cancer Center. I consider myself a computational oncologist. I actually work a lot behind the scenes to try and study the genomes of tumor cells as well as the immune microenvironment to better understand the disease. And so today I'm going to be talking with you about the emerging world of bispecific antibodies for multiple myeloma. But before we talk about the medicine, let's talk a bit about the biology. So many of you are aware that the immune system is very complicated. It is comprised of specialized cells that are involved in fighting infection, but also in fighting cancer. We can think of the immune system as a family tree with two major branches. You have the myeloid branch that consists of cells that can make neutrophils, red blood cells, and platelets. But on the other branch, you have T cells, B cells, and natural killer cells. The B cells are particularly relevant today because these are the types of cells that go on to make plasma cells, which is the cell type that becomes multiple myeloma. Plasma cells are normally the cell type that makes antibodies or immunoglobulins. These are proteins that stick to bacteria, viruses, and tell the immune system to clear them. But here today we're going to talk about how humans have engineered the antibodies of plasma cells to have a very different function, which is to directly target myeloma cells. So we're going to talk about that biology in just a moment. But first, let's talk about T cells. So T cells are one of those lymphoid branch cell types that are really essential for both recognizing and eliminating multiple myeloma. So they recognize it with a receptor on their surface called the T cell receptor. And this feels around all of the other cells in the immune microenvironment, and it comes into contact with another receptor on another cell, and within that handshake is a piece of the cell that it's displaying, letting the T cell know something is wrong with me, or I'm healthy, move along. And so when a myeloma cell does this, usually it's giving off a signal to the T cell there's something wrong, and the T cell will send protein signals to the myeloma cell, causing it to die. In fact, this process of T cells recognizing abnormal cells in your body and preventing them from going on to become a cancer happens all the time. It happens in me, it happens in you, it happens all the time. But over a period of time, myeloma cells can outsmart the immune system, and they can learn ways to avoid recognition by T cells. For example, their receptors on their cell surface that would let T cells know there's something wrong can be downregulated, so they are no longer being expressed so that the T cells can't even see them. Furthermore, the myeloma cells can send signals to the immune system that shuts down T cells so they're no longer effective. So to combat this, we have developed bispecific antibodies, a type of immunotherapy that redirects the T cells to locate, recognize, and kill myeloma. So bispecific antibodies are proteins. They compose of two ends. One end recognizes T cells, specifically the CD3 antigen on T cells. And the other end recognizes myeloma cells, specifically the BCMA or other types of proteins we'll talk about. And when it recognizes and connects the T cell to the myeloma cell, that T cell can now send that death signal to the myeloma to kill and eliminate the myeloma cell. So this is how we overcome that lost recognition of the immune system to myeloma. Now, this may sound familiar to you, as CAR T cell therapy also utilizes patients' own T cells to fight myeloma. But here's a brief slide to sort of show some of the main differences. On the right side, you see CAR T cell therapy is a complex therapy that involves acquiring T cells, genetically modifying them, growing them, inserting them back into the body, and waiting for a response. This is expensive, time-consuming, and can, as a result, not be available for everyone. Bispecific therapy, on the other hand, is off the shelf. You could, if your insurance approves the therapy, the next day you could be receiving it. So it's a more immediate type of therapy. But the big difference is really the schedule of how we give the therapy. CAR T cells is one and done. It's a one-time infusion, and you're no longer on therapy after the CAR T cell infusion as long as it's working. It's a living therapy. It's a living T cell that lives in your body. Bispecific antibodies, however, are proteins that will degrade over time. It's not a living therapy. It requires continuous injection of the drug so that it can maintain that T cell myeloma interaction. So I show these series of calendars to you to indicate that this is something that you commit to for as long as it is working. Currently, there are 3 bispecific antibodies approved by the Federal Food and Drug Administration for the treatment of multiple myeloma. These are teclistamab, elranatamab, and talquetamab. We can call them TEC, ELRA, and TALC for short. They were approved in 2022 and 2023. And the difference is that some of them recognize different proteins on the surface of myeloma. Teclistamab and elranatamab recognize the same protein, BCMA, which stands for B-cell maturation antigen, and talquetamab recognizes GPRC5D, a separate protein on the surface of myeloma. So we now have at least 2 different subtypes of bispecifics recognizing different types of proteins on myeloma. When a new therapy becomes available, the FDA sets regulations and guidelines for who should receive it. Not just anybody can receive a new therapy and expect their insurance to pay for it. Instead, it is approved under the same conditions in which it was tested. So the trials that found success and resulted in FDA approval had these specific kind of patients in them. They were relapsed refractory multiple myeloma who had received at least 4 lines of prior therapy, including a proteasome inhibitor, such as bortezomib, carfilzomib, ixazomib, and an immunomodulatory drug, such as lenalidomide, pomalidomide, and thalidomide, and an anti-CD38 monoclonal antibody, daratumumab, ixazomib. So currently, to receive a bispecific antibody, you need to meet these requirements unless you enroll in a clinical trial. So how is it administered? Fortunately, it's not too bad. It's a subcutaneous injection, which means an injection in the skin, usually given in the abdomen, as shown in the picture. It's given in 2 phases. The first phase is a monitoring phase. It's a step-up dosing. It's a test dose, you can think of it, to make sure that you're not having any severe reactions to the medication. And the next phase is given outpatient, and that is at the full dose, and it's until you progress. Let me talk a little bit more about that. So for teclistamab and talquetamab, we at our institution do a 7-day inpatient observation where the drug is administered at increasing doses on days 1, 3, and 5. So on days 2 and 4, we just observe you, and on days 6 and 7, we observe you. Elranatamab is a little bit easier. It's only a 4-day hospitalization. We give treatment on day 1 and day 3, with a break on day 2 and observation on the last day before you go home. After the patient has done well with the observation, assuming no major reactions, then they go to the full dose outpatient, and they continue that every 1 to 2 weeks. So I said every 1 to 2 weeks. Why not 1? Why not 2? Well, there are some specific recommendations by the FDA on how frequently it should be given. My recommendation is if you have lots of disease and you're trying to get it into control, it's best to do it every week until you've achieved at least a partial, or if not a complete remission from the therapy. At that point, it's okay to back off a bit and do the therapy every other week. So that means going to the clinic 2 times per month to receive your treatment. It's nice that you don't have to receive a lot of additional pills for this specific treatment. Now let's talk about side effects. No medication is perfect. There's going to be some side effects. The biggest side effect we worry about with bispecific antibodies is something called cytokine release syndrome, or CRS. Here are some comparisons of the frequency that we see of those side effects for each of the drugs in their initial trials. So up to 77% of patients had cytokine release syndrome in these studies. I'm going to be talking a bit more about what that means and how we can even reduce that number to substantially lower. The other thing it can do is lower your blood counts. So we're talking about neutrophils, red blood cells, platelets. This might require you to have a blood transfusion or a platelet transfusion if they drop significantly. It also could increase your risk for infection because neutrophils are really important for preventing infection. It could also cause some neurotoxicity, and I'm going to talk a bit about that in a moment. But note that the rates of that is pretty low, only around 10 to 15%. Let's deeper dive into cytokine release syndrome, so CRS. As mentioned earlier, it's similar to a very severe flu. You might have fever, body aches, low blood pressure. Your blood tests might indicate high inflammatory markers. In more severe conditions, it might result in difficulty breathing, low oxygen, and very severely, it could cause organ failure or cognitive dysfunction. The cognitive dysfunction in CRS is primarily related to the fever, as I noticed that when patients have very high fevers, they become a bit delirious and confused. When the fever goes away, they return back to normal. But there can be some more significant neurotoxicity, and we call this the immune effector cell-associated neurotoxicity syndrome, or ICANS for short. And here we can see some more severe confusion, visual and auditory hallucinations, language and speech dysfunction, for example, word finding ability, headaches, tremors, even seizures can occur. Some fine motor impairment might be some early signs that this is happening. Because of these severe side effects, CRS and ICANS, we recommend that initial inpatient hospitalization so we can observe patients very carefully for these side effects and react immediately. The good news is most of our patients don't have any of these side effects and do really well because we give a lot of preventative medications I'll be talking about. And if you do have some of these side effects, they're reversible. That's not a permanent, life-changing side effect. I mentioned we can do some things to prevent CRS and ICANS. So before every dose, we recommend a steroid, dexamethasone, an antihistamine like Benadryl, and Tylenol to prevent fevers. We've also been recently studying using tocilizumab, an anti-IL-6 monoclonal antibody that binds up one of the inflammatory proteins released by your immune system during the treatment. This will calm down the immune system and prevent overreaction so you don't have as severe symptoms. What if you do get CRS or ICANS? What do? Well, believe it or not, it's about the same as the things that we do to prevent it. We give Tylenol, we give steroids, and we give that interleukin-6 antibody, depending on how severe the patient is. Now, I mentioned to you that our institution has done some studies looking at ways to reduce the CRS. And so we used tocilizumab in about 70 patients over the past year, and we compared the rates of CRS and ICANS. And we found that with this tocilizumab pre-treatment, we reduced CRS down to about 10 to 20% compared to the 77% we saw in the clinical trials. So now the symptoms are just 1 in 5. And most of the patients who are experiencing CRS is very mild. We're talking about a fever that we can address with some Tylenol. So I laid out all those side effects not to scare you or to deter you from receiving bispecifics, but to do my due diligence and let you know that these are possibilities. But again, I think that we have great medication to be able to prevent the side effects. Because the treatment can lower your blood counts, you are at increased risk for infection. And so we do also recommend preventative antibiotics for all patients. We use levofloxacin, Bactrim, and acyclovir. Many of you probably have already been on these medications before if you have myeloma. We also regularly check the immunoglobulin levels. Again, immunoglobulins are antibodies. They're made by plasma cells. And since we are directing our treatment at plasma cells, your normal antibody levels are going to be low. So intravenous immunoglobulin, or IVIG, is an infusion of donated antibodies that we extract from human blood and can give back to patients. So we definitely recommend this if your IgG level is less than 400. Talquetamab, which is a bispecific antibody binding to GPRC5D, has some unique side effects that we don't see in the BCMA binding bispecifics. These are primarily oral and skin and nail side effects. The oral side effects may include change in sense of taste, dry mouth, difficulty swallowing, and even mouth sores. Skin and nail effects can be just a simple rash or dry skin. Patients who have these side effects, we do provide a list of things that you could try and mitigate those side effects. We recommend anyone with oral symptoms see a nutritionist to make sure they're still getting in enough calories. We don't want loss of appetite to result in weight loss. And any patient with skin abnormalities, rash or nail problems should see a dermatologist. So we have some tips here on things that you can do to prevent mouth sores, like baking soda and salt rinses, things you can do to enhance the flavor of your food by adding more spices or herbs, as well as using citrus in your cooking. You should avoid metal utensils if you have a metallic taste after eating. Sugar-free candy and gum should also help saliva stimulation and prevent dry mouth. Drinking lots of fluids, adjusting the temperature of your foods to your liking. Limit caffeine and alcohol. Saliva substitute sprays are available that you could use. And of course, using smaller bites of food and purees if you're having difficulty swallowing. Patients with skin and nail finding abnormalities should avoid hot showers or excess water. They should use moisturizers immediately after the shower or exfoliants. They should smooth the nails with a file, and use even clear nail polish or hardeners to strengthen their nails. And biotin supplementation has been recommended by our dermatologists. All right, so we've talked about the side effects of bispecific. Let's talk about the why. And I'm going to just simplify it for you here and show you the median progression-free survival in bold for each of these treatments and their initial studies that came out. So these are the studies where patients had at least 4 lines of therapy and were refractory to the best drugs on the market. And we saw at least 11.8 months in progression-free survival, which is the duration of time that the patient's disease was in control while receiving the therapy, which is pretty good, all considering the types of patients these were. And around 39% in the teclistamab group had a complete remission, meaning no measurable disease after treatment. However, not every patient did well. About 1/3 of patients you can see on the far right had progression of disease after receiving bispecifics. So the big question is why? And this is where my research is primarily focused. I mentioned I'm a computational biologist. I like to study the immune system. I like to study the tumor cells and get into the weeds and figure out what's going on so that we can make adjustments to our treatments so that we can achieve longer remissions. And I'm going to use this very simplified slide to show 2 main reasons why these treatments won't work. On the first, we have exhausted T cells. So that's a real scientific term. It means that T cells over time, after repeated stimulation by the immune system or by the tumor cells, stop functioning and they just don't work anymore. It doesn't matter if you bring them right up next to the tumor cell. It won't know what to do. I believe the reason for this is because we have evolved mechanisms to shut our immune system down to prevent autoimmune disease. We don't want our body attacking ourselves. And so these exhausted T cells are going into this state to prevent reacting to their own body. The other problem that we see is loss of the BCMA target on the surface of myeloma. This can be a complete deletion of the BCMA, so it's no longer visible, or it can be a mutation in the BCMA protein so that it's visible, but it's not recognizable by the bispecific therapy. About a third of patients will acquire the deletion or the mutation in the BCMA protein. In fact, some patients, we can detect this through DNA sequencing before they undergo treatment to make sure they don't have these abnormalities, so we don't waste their time. The problem with the exhausted T cells, though, is many patients have exhausted T cells after years of myeloma treatment. And so I think one of the ways to get around this is to try and get bispecifics introduced earlier in the disease treatment. And Dr. Hansen today talked about some of the clinical trials that have shown better efficacy when we give those treatments up sooner. And if that's interesting to you, I'm going to talk in the end about some of our clinical trials looking at that very question. Now, how do we get around the fact that BCMA is lost from the surface of myeloma? It seems like an unsurmountable problem for these therapies. Well, actually, not so much. Because there are at least two bispecifics that recognize different targets, BCMA and GPRC5D, studies are looking at doing combination bispecific antibodies. Here's a recent study that was just published in our premier medical journal showing very high response rates when we combined both teclistamab and teclistamab, 52% complete response rate compared to 39% in the earlier study using one drug alone. But what was even more impressive, at 27 months, using the best dose in this study, which is the gray line, at 27 months, there was around 70% of patients who had not yet progressed, much better than the 11.8 months that I was quoting in the single agent. So I think there's a lot of promise in combining multiple bispecifics so that we can overcome if one of the targets is lost, we still have a backup there. So I mentioned exhausted T cells are a problem, especially the later on in the stage of the disease. And so giving bispecifics earlier on will have substantial benefits, we believe. In fact, there was a study published by Moffitt earlier this week that looked at actually the T cell fitness in the patients at early time points versus later and found that the T cells are substantially more fit when we use that earlier time points. So here are 3 clinical trials I'd like to advertise that are using bispecifics at an earlier stage. The first study is using linvoseltamab, a BCMA bispecific that's not yet approved, but it's on its way to approval. And this is being used in newly diagnosed multiple myeloma, and it's specifically used in patients who do not achieve MRD negativity after induction. So if you get induction and you haven't achieved MRD negativity yet, linvoseltamab might be that extra boost that you need to get yourself into remission. The second study I'll advertise also uses linvoseltamab, also in newly diagnosed, but it does so in combination with lenalidomide, a well-established myeloma therapy that works to augment the immune system. So in combination with the bispecific, I think we can see some potential very good results. But what about using bispecifics before myeloma diagnosis? So patients with high-risk smoldering myeloma, this is a precursor to myeloma. These patients have about an 80% chance in developing myeloma. If we give teclistamab or talquetamab in combination with daratumumab, we hypothesize that we can prevent or delay the disease from ever happening. So if this is of a particular interest to you, you can please reach out to us and we can talk about this study. There was one mention at the end of the last talk about what are we going to do about those darn painful bone marrow biopsies. Well, I don't know if I can completely get rid of the biopsy, but one thing that we're investigating, I'm the principal investigator of this study, is ways to ease the pain. And so we're investigating Portomar, which is a new device that enables the biopsy to bypass that painful layer of the bone that makes the procedure so uncomfortable. It's a screw that literally goes into the pelvis bone. It's placed under anesthesia, and patients are not going to be awake during that procedure. But then the subsequent biopsies are done through that port, sort of like the ports you get in your skin to access the blood. so that the repeat biopsies are not as uncomfortable. So if this is of interest to you, you're welcome to reach out. So in conclusion, I want to thank you all for your attention, the invitation to be here today, and all of the great team that we have at University of Miami. Here's a picture of just some of our team taken this summer. We are always available for second opinions. I know the Moffitt team is outstanding and highly recommend them. But if you need access to a different clinical trial, we're here for you. Thank you again.